Good afternoon, everyone. Welcome to Clinical Toxinology. Is it relevant to medical students? This webinar is now at Season 4, Episode 4, under the supervision of Prof. Khaldun. What a long way we have come. My name is Lohit Silan.
And my name is Tanzi.
And we'll be your moderators for this afternoon. This webinar is organized by the Department of Emergency Medicine of Hospital Chancellor Tuanku Mukris. For your information, we also collaborated with several esteemed organizations to ensure this webinar's success, namely Remote Evaluation Consultation Service, Malaysia, Society of Toxinology, College of Emergency Physician, Special Interest Group in Toxinology, Special Interest Group in Clinical Toxinology, College of Emergency Physicians, Academy of Medicine Malaysia, Malaysia Biodiversity Information System, National Poison Center, University Science Malaysia, and TOXT.
Before we begin, here are a few housekeeping notes. Participants, please feel free to ask questions through the Zoom Q&A. The questions will be addressed at the end of every case. There will be a feedback form at the end of the webinar to receive your certificate of participation. Also, a small reminder here, there will be a Kahoot quiz session at the end. Do stay tuned and stand a chance to win grand prize. There's only one prize for the champion. Now, let's welcome Dr. Irene Binti Zamhud, the emergency physician in the Department of Emergency Medicine, Hospital Chancellor Tuanku Mukris, for the opening speech.
Hi, Assalamualaikum. Hi, everyone. Welcome to this important webinar on clinical toxinology. First of all, I want to thank all of you for inviting me to give an opening speech for this webinar. So as an emergency department physician, I can say that our brings us face to face with toxinology emergencies more often than not. So for us, we have to have the skills to recognize and also the skills to manage these cases quickly, which actually can make the difference between life and death for our patients in our ED. So I would like to thank all the panelists, Dr. Emilia, Dr. Zainal Abidin, Dr. Sataria for joining us today. A special thank you as well to Associate Prof. Dr. Khaldun for encouraging the students to participate in this and for being their program advisor. I want to also congratulate the organizers and also all the participants for making this possible. So thank you so much. And I look forward to the discussion ahead. That's all from me.
Thank you so much, Doctor, for the insightful speech. Moving on to introducing our advisor and also one of the panelists of today's webinar, Prof. Madya Ahmad Khaldun Ismail. Prof. Khaldun is an associate professor at the Department of Emergency Medicine, University Kebangsaan Malaysia. He is a visiting scholar at the Graduate School of Medicine, Tohoku University, Sendai, Japan, honorary consultant at the National Poison Center, University Science Malaysia, and expert resource at the Malaysian Biodiversity Information System, Ministry of Natural Resources and Environmental Sustainability. He served as a member of the WHO Global Roster of Experts for the Prevention and Control of Snakebite Envenoming and is the founding advisor of Remote Envenomation Consultancy Services. He also holds advisory position in the Malaysian Society on Toxinology and Philippines Toxinology Society. He is a member of the International Society on Toxinology, Asia Pacific Association of Medical Toxicology, and Japanese Society of Clinical and Analytical Toxicology. He has authored various publications in related fields. Now, let's get to know our panelists for today's webinar. Today, we are fortunate to have with us 3 experts who will help us explore this theme through real clinical cases. Let me introduce Dr. Emilia Binti Santa Maria. She is an emergency physician, disaster medicine expert, and widely recognized as a pioneer and prime mover in advancing toxinology in Philippines. She earned her Doctor of Medicine from De La Salle University and completed her residency in emergency medicine at the Philippine General Hospital. She later obtained her master's in disaster risk management from Batangas State University. Dr. Santamaria is a founding member of the Philippine Toxinology Society and has led multiple national and regional training initiatives on snakebite and marine envenomation management. She is affiliated with the Asian Remote Envenomation Consultancy Services, the Philippine College of Emergency Medicine, and the Health Emergencies and Disaster Study Group at NIH-UP Manila. With research interests in emergency medicine, toxinology, EMS systems, and disaster response, she has co-authored publications on snakebite epidemiology and management and disaster response. She currently serves as a lecturer at the UP Manila Disaster Risk Reduction Management for Health Center. Dr. Santamaria continues to advance clinical and public health preparedness, contributing to regional capacity building in toxinology and emergency medicine across the Southeast Asia.
Next, we have Dr. Zainal Abidin, a highly accomplished consultant emergency physician at Hospital Tengku Ampuan Afzan and the state head of emergency medicine in Pahang, Malaysia. He holds multiple honorary positions, including honorary lecturer at Bidat University College, honorary consultant at the National Poison Center, University Science Malaysia, and expert resource at the Malaysia Biodiversity Information System, Ministry of Energy and Natural Resources. Additionally, he serves as the Vice President of the Malaysian Society on Toxinology, consultant for remote envenomation consultancy services, and an executive committee member for the College of Emergency Physicians Malaysia. Dr. Zainal Abidin is actively involved in producing guidelines on snakebite management, STEMI, pre-hospital thrombolysis, and Pahang Health Emergency Disaster Risk Management, as well as conducting educational programs and life support courses for students, healthcare providers, and the public.
Lastly, let us welcome Associate Professor Dr. Sataria. She is an attending staff and consultant, Department of Emergency Medicine and Ramati Debodi Poison Center, Faculty of Medicine, Ramati Bodi Hospital, Mahidol University. Her journey began with MD, Thai Board of Internal Medicine, Thai Board of Emergency Medicine, Certification of Academic Fellowship of Emergency Medicine, University of Florida, USA, Thai Board of Clinical Pharmacology and Toxicology. She is also a director of the Clinical Pharmacology and Toxicology Fellowship Program, Thai Society of Clinical Toxicology, Chief Editor of the Thai Journal of Emergency Medicine, Thai College of Emergency Physicians and Committee, and a working group on venomous marine animals in Thailand.
Now, Zee, I believe we can officially dive into clinical toxinology. Can you please introduce to us what clinical toxinology is?
Sure, Lohit. Toxins are organic substances produced by living organisms that function as venom or poison. These naturally occurring compounds, such as proteins, enzymes, and other bioactive molecules, can disrupt biological systems, harm target organisms, or even cause death. Clinical toxinology is the study of medical conditions caused by exposure to these natural toxins. It encompasses a wide range of scenarios, including envenomation by venomous terrestrial or marine animals, also poisoning from exposure to toxic substances from plants, animals, or fungi through ingestion, inhalation, and absorption. It's different from clinical toxicology, which focuses on synthetic, chemical, or toxic substances.
Before this webinar, we have conducted a survey among 36 final year medical students in the current emergency medicine posting at UKM to assess their awareness and confidence levels in clinical toxinology. And based on the survey, more than half of the students are aware of what clinical toxinology is all about. Next, as we can see here, about 3/4 or even more of the students are not confident in providing information on the appropriate safety and health-seeking behavior regarding toxin injuries, such as informing the public that toxin-related injury is a medical emergency, various emergency services, and appropriate healthcare facilities that are available for toxin injuries. Also, less than 10% of the students are confident in providing information on the role of remote envenomation Consultancy Services, also known as RECS, which offers training and 24-hour on-call consultation service in the clinical management of toxin-related diseases to the healthcare professionals in ASEAN since 2010. Next, again, majority of the students are not confident in sharing their knowledge, such as identifying the common signs and symptoms of a toxin-related disease, appropriate first aid measures for acute exposure to natural toxins, various sources of natural toxins, emergency hotlines, guidelines, and resources for toxin-related disease, and appropriate antivenoms that are available in Malaysia. Similarly, majority of the students are not confident in providing instruction or information on how to identify a potential toxin injury and administer the appropriate first aid as well as the emergency procedures in cases of suspected toxin exposure. They are also not confident regarding the important history details that need to be obtained and where one should be transported to after a toxin injury. So, in comparison to the survey done over the past 3 episodes, we can see that only a minority of the students in the current group, and similarly in the 2 previous groups of students from episode 2 and 3, are confident in providing information to the public regarding clinical toxinology. So in summary, we can see that majority of the students are not confident in clinical toxinology. Hence, it's our hope that this webinar will shed some light on this topic, which is relevant to the medical students and healthcare professionals, as our country has diverse venomous or poisonous species in the forest, under the water, or even in our own houses. So, in this webinar, we are going to discuss a few clinical cases with our expert panelists. For your information, these are actual clinical cases in Malaysia that were referred to RECS in the past. Without further ado, let's begin our first case discussion involving a cute and innocent-looking animal.
Okay, in our first case, we have a 27-year-old male with no known medical illness complained of being stung on his right foot by an unidentified marine animal while swimming at Pulau Banggi, Sabah. He rated the pain score as 5/10. He was able to swim to shore and went to an army camp which is located an hour away. And he was given mefenamic acid 500 milligrams. However, the pain was not resolved. He then went to the nearest health clinic which located 2 hours away. Upon further history, the pain did not resolve and was worsening, and upon arrival to the health clinic, he claims that the pain score was rated as 8/10. So at this point, to all the panelists, what is the possible marine animal that can cause these symptoms?
I'd like to invite all the panelists to turn on their camera and turn on their mics.
Yes, please. Yeah, maybe Dr. Emilia and also Dr. Zaina. Can you guys on your cam?
Since Prof. Sataria is there first, maybe Prof. Sataria would like to give your thoughts about this. What do you think could cause, or any other questions you would like to ask to clarify?
Yeah, thank you. I think that I would like to see the lesions that he was stung, what it's look like, and I think maybe it can be like jellyfish or right other. I'm not sure if that is the fang. Maybe this can be right the snake.
Yeah, that's very interesting. Maybe in the question, in the history was not clear. It just says swimming, but how exactly he got stung? Was he really swimming, or was he walking in the sea? How deep in the sea was he in? Is there? What do you think? Do you think that's important? Maybe that will give us some better idea, isn't it? The mechanism of injury itself. Was he walking when he got the injury, or was he actually swimming, floating, or suspend, or in the water? Any information, moderators?
Unfortunately, we do not have any information regarding all this. Yeah,
So,
maybe we can
so
have a look on
yeah,
the.
maybe Dr. Zainal, ask our panelists first. Dr. Zainal, maybe you want to, at this point, what do you think? Other questions you want to ask?
Yeah, I think Prof. Khalil already asked. And then anything that did he done to the wound after being stung?
Okay,
Any
right.
any description of
Yeah.
the area the sting is located, the right foot? Any description of the injury? I mean the site of the injury?
Okay.
And then does he's alone at that time, or anybody else also been stung?
Yeah. Did he see any animal, right? Anything that actually sting him or bite him, or that caused the injury? Nothing. Okay. So maybe the moderators can highlight a bit, give us some clearer idea about this case.
Yeah,
So there are
so
many questions. There are many questions that, with very limited information, we cannot jump to conclusion. Basically, this is being proven by all the responses by the panelists. Okay.
yeah, sure. Maybe you can move to the his presentation at the clinic first.
Okay.
Okay, so when he was presented to the clinic, his GCS is full and he is pink. The pharynx was warm and the pulse volume is good. He's not tachypneic, not tachycardiac. And then respiratory rate was normal, 18 breath per minute. Temperature is normal, afebrile with the reading of 36.8 degrees Celsius. SpO2 normal, 100% under room air. Pain score rated, as mentioned before, 8/10. The lungs on examination is equal bilaterally. CVS, dual rhythm, no murmur. Abdomen soft and not non-tender. And there's no any palpable inguinal or groin lymph nodes. However, upon the lower limb examination, it is normal. However, upon the right lower limb examination, there's a swelling up to below right knee and also tender over right calf. There's also a puncture wound noted over the ball of the right foot and also plantar aspect of the base of third digit. And thus key discoloration was noted over the third digit as well. And there's limited range of motion due to swelling. However, there's no bleeding. And SpO2 over the third digit is 98 to 99%. CRT less than 2 seconds over all toes. And the sensation is intact and equal bilaterally. Yeah, this is all the information that we got. Unfortunately, I think the only information that we have is patient is swimming alone in the sungai. Yeah, that's it. And he didn't see any marine animals. Didn't notice any marine animals. Yeah.
Is it in the river? Was he stung in the river or in the sea?
In the sea, sorry.
Okay. So can we see? Is this the actual foot of the patient? Actual picture?
Yes, this is the actual picture.
Okay. Any possibility to zoom to the picture? Okay. Can see the dusky discoloration of the right third toe, right? We can't see any puncture wound there. It's on the plantar area. Okay. Okay, so what do you think, panelists? Does this give us some idea what could be the cause? Is it a jellyfish?
I don't think so.
Doesn't looks like, yeah. Yeah.
So he probably stepped on something, right? Rather than
Yeah.
actual swimming.
Yeah.
So jellyfish is
Something.
probably not.
Do you have any? Yeah. Do you have any pictures of the affected foot? Or just only this picture?
Yes, we do have more pictures. Let me show.
Oh, okay.
Okay.
Oh, okay. All right. That,
So it was a single puncture wound on the lower aspect of the. So he was stepped on something, and it was not because he was swimming, isn't it? Was it?
Yeah. He said he was swimming, but actually, by looking at this,
It's
unlikely from the
walking.
swimming. It's more like, yeah, he was wading in the
Uh,
water or something, and then stepped on something. So the discoloration is due to, what do you think could be the cause? Is it ecchymosis, necrosis, vasoconstriction? What do you think, Prof. Sataria?
I think it does not look like jellyfish because
Right.
we
Yeah.
don't see the lesion like jellyfish.
Mhm.
However, if he stepped on something, I think this type of marine animal might cause vasoconstrictions for
Mhm.
the lesion. But I'm
Mhm.
not sure because we don't see any like the lesion of like the fang or other lesions on
Mhm.
his toe.
Single puncture.
Yeah.
Yeah.
How about like other symptom like
Uh,
uh besides only like discolorations? How about like other like
there was pain, severe pain
uh
there, 8/10.
artery?
Yeah.
Uh,
So what do you think? I
uh,
think it looks more to me. It looks more like an ecchymosis. What do you think?
yeah,
You know,
yeah,
Yeah,
mechanical
agree.
injury.
agree.
Did he uh, apply tourniquet on the
Oh,
toes of after the incidents? No,
No.
No.
no,
okay.
okay.
Yeah.
So the puncture
So
is
yeah,
already more proximal than the
yeah,
of the toe. Yeah. Okay.
okay.
On the leg. Okay. So so do we have now a bit more clearer idea? It's not
Mm,
jellyfish, definitely. Could be
yeah,
something with spines or something that
yeah,
can bite, and that explain mechanism. Swimming could have been better clarified, especially when you are the doctor asking question. The patient say I'm swimming, but actually the mechanism wasn't clarified. So just by looking at the physical presentation, we think that most likely something that punctured the patient. It could be an animal, could be just a sharp thing under the sea he may stepped on. It could be anything, may not be an animal, but we'll see. So that's why I think we have to ask for more information, and maybe the moderators can highlight us a bit more
Yeah.
how the things progress.
Yeah, sure. So I think currently all the panelists believe that this patient is actually stepped on something, right, instead of being stung by any of the marine animals. So why not we go to have a look on the management. So for the initial management, they actually done a hot water immersion of the patient's right foot, and also analgesia and intramuscular tetanus toxoid and also antibiotic was given to the patient. So by that time, the full blood count level shows the raise in the total white cell count, which is the reading given is 19. And also there's the granulocytes is 16.8, which is also increased. And also there's a increase of clotting time, which is up to 10 minutes. So this patient was then transferred by boat to the hospital for further management. Yeah, and this is the picture of the right foot.
Can you zoom into the picture a bit?
Yeah, sure. So
Okay.
so
Is this worsening than earlier picture, or is this taken at the same time?
I think taken at the same time, but we can notice that there is a little bit swelling over
Mhm.
the toes.
Okay.
Yeah.
And I think the erythema already on the dorsum of the foot, right? Yeah.
Yes.
Okay. So maybe our panelists would like to. What do you think at this stage could be the cause or potential cause of injury, or what we should do? Are you okay with the management there given? This was why was patient transferred by boat? Patient was somewhere else when this injury occurred. It was on an island or something.
Yeah, he was at Pulau Banggi. I'm not really
Ah,
sure.
Pulau Banggi.
Yeah.
Okay, Pulau is an island. Okay,
Yeah.
so he was
So
on an island. So he was treated in maybe a local facility, clinic or something like that. And then he was transferred and referred to hospital. Okay. Right. What do you think of the management there? This management done in the clinic before transfer, right?
Yes.
Okay. So hot water immersion, anesthesia, we don't know what was given. IM tetanus toxoid and antibiotics, we don't know what antibiotics. And the clotting time is 10 minutes. I'm not sure why they do clotting time, but okay. So, Dr. Zainal, maybe.
So the management was done in klinik kesihatan. I thought, is it? Was it?
Yes.
Clinic.
Okay.
Army clinic.
Yeah, most likely.
Yeah, primary. How they did the clothing time? Not sure.
Good question.
Not really sure. So far, the information that we have. Yeah.
I see.
Yeah.
Okay.
Is the hot water immersion mentioned how it was done? No.
No.
Okay. So those are very important points that we need to ask as well.
Okay.
Okay.
Do
M,
you have
what?
do you have the exactly what sort of analgesia and antibiotics was given to the patient? No.
No.
I see.
Okay, we're still in the dark a bit.
Was there any foreign body noted right after the? I think we were not able to ask that if there was like any foreign body
Yeah, something sticking in the wound, maybe.
sticking out of the wound or anything,
Okay.
Yeah, no.
and maybe the patient removed it or something.
No, apparently not.
Yeah.
Yeah,
Uh,
I think the hot water
Zakaria?
immersion yeah.
Yeah. Hot water immersion, sorry, go ahead. Could be this redness because of the hot water immersion.
Hot water.
But
It could
it's
be a
only the third digit,
secondary.
Dr. Cal.
Yeah,
It's
we
only the
didn't know.
third
We didn't
digit.
know. That's one of the things that we should ask if you see something a bit strange here. So,
Yeah.
Prof. Sataria, what do you think? Are you okay?
Yeah,
Or
I'm okay. I
you-
wonder that how long that from the exposure of this animal to
uh,
my initial management. I agree that because the patient had a lot of pain, and so we have to try to reduce his pain by analgesia and hot water immersions for mild immunomations. I agree with that, and TT and antibiotic. I think if I'm not sure that he has any underlying disease, and the antibiotic should like cover for right VBO or something like that if the patient has the underlying disease. However,
yes.
I still wonder because we don't see the lesions of the stung or like even the bite. Uh, I still worry that is possible to be like the sea snake bite.
Mm.
Because if the sea snake eats the patient, it can cause like neurotoxics and rhabdomyolysis. So when
Okay.
you transfer, you have to prepare for like the airway management or
Mhm.
other that might occur. Um, right
Yeah.
in this case, yeah.
So you're thinking on the worst case scenario. So
Yeah,
that's very important as an emergency physician, right? We always
One
think of
step
the worst
ahead.
thing and try to prepare and anticipate. But
And
just from the current one, if you can see the wound earlier just now, just a single puncture wound, and then there's a swelling, and then there's a severe pain. Doesn't really paint a picture of a sea snake bite. So sea snake is typically very small teeth, and the puncture wound doesn't cause much bleeding, and doesn't cause much local inflammation, and therefore not much swelling and pain. So that's why some say if you get a bite from sea snake, is typically supposed to be painless bite, and you might not be aware that you were bitten unless suddenly you get early neurotoxicity, systemic neurotoxicity signs, and also myoglobinuria as well. But in this case, I don't think it is sea snake. Unlikely, sea snake doesn't just wait and to be stepped on. They just swim away. That's one more
Yeah,
thing.
they swim
It
away.
runs away from any danger rather than wait for, like, pit viper. Very, very unlikely it's a sea snake. Other animals that maybe just stay where it is, that come to my mind is a stonefish. So that is typically will be half buried or just on the surface of the floor of the sea. Doesn't really run away, just stay there, hoping that camouflage can help him get away from you. But we obviously did not see it, and therefore we stepped on it. So that's another thing. One more question I think that we missed in the history is, did patient wear any protective footwear when he was
Yeah,
walking in the sea? Was he wearing a booty or just barefoot?
that's it.
Yeah. In this picture, I think most likely it's a barefoot, right? Most likely, yeah. Because if he's wearing booty, we might also possible get the foreign body stuck onto the booty, for example, a broken puncture,
Yeah.
broken stinger.
I'm
I
also
just want to ask,
thinking,
the thing that threw me off is the clotting time. I don't know why it was taken. One. Second is 10 minutes. So that comes to the question, how that Dr. Zainal said, how was this done, right? So we know that the clotting time that you use for using that you do bedside, we typically ask to do it on a glass bottle, clean glass bottle, and not plastic tube or something like that. Because we need to initiate the clotting cascade by the cracks, by micro cracks in the glass. So if you don't use this glass, and you might not have the cascade to start, the contact pathway to start. So therefore, you might have a prolonged coagulation period to see it. You will not get to see it in that time. You will not clot. Okay, so you get a false positive, what do you call, results by actually doing the wrong method of testing. So that's
I,
why you have to ask of these things. Okay, yeah, M.
I'm also thinking, Doc Carl, because like, how come it's only the third digits that's swelling that way?
Okay.
And yeah,
Yeah,
I'm so localized, and if it's really some sort of an envenomation, the whole
yeah,
foot will start to have or show us something.
yeah. I mean,
Yeah.
you can see that the puncture wound is actually at the ball
The
of
bottom.
the toe
Hmm.
and the plantar one. So that could be mechanical, but you can see the swelling has spread, including the erythema, to the whole toe and also neighboring toe, and also the dorsum of the foot, and also the swelling goes up to below knee. So that's a sign of envenoming, definitely, not just a mechanical injury. So the only thing that I can think of at the moment is stonefish that we commonly encounter with similar symptoms. Do we have any tests that we can do specifically for stonefish? The answer is no. There's no there's no screening for stonefish venom that we use. So it's purely at the moment. So what do you think at the moment the diagnosis, Lena, that you differential diagnosis that you would give?
Yeah, possibilities is animals with stings such as stonefish or stingrays, but I think because of
The location.
the local envenoming, I think more of the stonefish. rather than stingray.
Stinging
Yeah, I
fish,
agree.
yeah,
Yeah,
all kinds of various different stinging
yeah,
fish that we have.
stingrays.
Okay, yeah. Okay.
I agree
Sabaraya?
with
Yeah.
Professor Kadun. Yes, the spiny fish should be one of the differential diagnosis because
Yes,
it's
definitely.
pain, and we have to ask more like neurological symptoms.
Yeah.
But I don't
So,
think this
Or
case has. But okay, thank you.
yeah, I
maybe
would also,
a broken
yeah,
spine, doc. I mean a broken spine.
yeah, could be. We don't know. We didn't see the surface, right? But we don't know what's inside, and therefore that's why it's sent to hospital. So I assume you're going to order for X-ray of the foot at least
Yeah,
to rule out any embedded foreign body that we
foreign
cannot see
body.
from the surface. That's is important decision as well in the emergency department. And then somebody mentioned just now. About blood tests. So, what blood test do you think? So you can see just now the blood result was the WBC was raised, right?
Yes.
Yeah, WBC was raised. Typical. So that one, the first one. So it's an acute leukocytosis, right? So that is typical also for envenomation, venom reaction. You can get acute leukocytosis on the first reading of the blood test. Subsequently, it will come down if you do a serial blood test. And then I think if looking at this, I would also look at the CK, the creatine kinase, because probably involve injuring the muscle in that area, and the venom may potentially destroy the muscle in that area or go into rhabdomyolysis maybe. But that's why CK could be important to monitor. And I don't see the reason for the clotting time for venom marine animals. Yeah, so or coagulopathy. I don't see the need for it. So to me, the blood test the most important. Okay, WBC to see that leukocytosis and could be monitor for maybe secondary infection later, and also the CK. Renal profile, depending on the patient status, if there's any other medical injury, medical condition that may require you to have a baseline, you can. That includes liver function test as well. Okay. Uh, okay. So can we proceed? How does the patient proceed?
Yes, Prof. Let's go more deep into this case. So for this patient, for his progression at the hospital, the working problem list by that time is unidentified marine animal bites and also rhabdomyolysis. And then the patient is maintaining well in the ward. Vital signs are stable. Pain score rated 3 to 4, and he was able to ambulate. Otherwise, there's no any shortness of breath or any chest pain. On the examination of the right lower limb, there's a swelling up to mid-thigh and also puncture mark noted over the plantar surface of third digit with blistering noted as well. The compartment was soft, CRT less than 2 seconds, sensation was intact. Dorsalis pedis artery and also posterior tibialis artery was palpable. As we can see in this picture, the swelling is already up to mid-thigh from initially below right knee, and it has now progressed up to the mid-thigh despite the management given. So to the panelists, do you have any thoughts on why this might have happened? Is it because of the envenomation progress or any other ideas?
How was patient put on during hospitalized on the bed? Was it raising his leg or is just a neutral position?
Neutral position.
Neutral position. Was he moving? Keep on moving, or rest in bed?
I think he was able to ambulate, right?
He's ambulating. He's ambulating.
Yeah.
Actively ambulate.
Obviously, there's progress.
Yeah, it is. It looks like the because of the envenoming effect.
Yeah.
Mm.
Satarya?
Okay,
Any
can I
comment?
ask how much for the levels of CK? Is it very high?
Is there any blood tests come back?
But test for
Yes.
lepromyelitis.
Serial?
The CK level is 895.
So it's raised a bit from
100.
before, but not too significant.
Yeah.
Is that the reason why they put diagnosis as rhabdomyolysis? I don't think that's appropriate, but anyway. Okay, so this is the results. Can you read subsequent one?
Yeah, sure. So for this patient progression at hospital, this is the investigation done. From here, we can see that the HB level, I think, is normal, and there's a rise in total white cell count with the reading of 17.2. Platelet is normal. The CK is also high, is very high, with the readings of 895. And then there's also prolonged APTT and also PT. Yeah, given the reading of 29.1 and 12.5. Yeah,
I
otherwise,
wouldn't.
I think
Yeah,
there's
I wouldn't say that 895 to be very high of a CK. If you have an IM injection, might also cause that reading. So subsequent reading needs to be done. Huh? Okay. Anyway, ECG, nothing significant, normal.
Yeah,
Sinus
so
rhythm.
far there's no the rhythm is the ECG shows sinus rhythm and there's no any ischemic changes noted. Yeah.
Okay. Arrhythmias. Okay. So augmentin was given. Okay. So what's the working diagnosis? Was this patient at this stage referred to Rex already or before?
Yes, I think this patient already referred. And their final diagnosis is this patient is being stung by stonefish.
Okay. So is that the working diagnosis lah now?
Yeah.
After.
So,
How does the patient progress after this?
I don't think we got the progression of this patient in the hospital. Yeah.
Yeah. Okay, just for the sake of discussion, then I think this kind of show, the important questions that need to be asked and clarified before reaching up to the conclusion. The conclusion is still a working diagnosis, a differential rather than the actual diagnosis. So we can't say it's actually stonefish because we don't have the evidence, but it may suggest from a spinous animal, marine animal. Because there's a telltale sign of envenoming from the from the clinical and also from the laboratory test that may suggest acute leukocytosis. CK may be high, but we don't have the subsequent reading, so we don't know the progression of the patient. So I think what's your plan, suggestion, Dr. Prof. Sataria, for this patient at this stage? What's your
I think
proposed?
that I will only like supportive care because I know that there is the anti-venom, but we don't have. So supportive care is enough. And in our experience for stonefish envenomations, I have never seen the patients with systemic envenomations or effects. So supportive care for me is enough.
Yeah.
Reducing pain, everything and TT that you have already given to him.
Okay. M?
yeah, and the continuous monitoring, doc, of all the important diagnostics just to
Yeah.
make sure that there's nothing more serious that's going on, and agree with the supportive care and treatment that was mentioned. And yeah, basically that's
Okay.
the
That's the plan. Okay.
next steps. Yeah.
Zaina, you want to add on?
Yeah, we don't have the antivenom for stonefish in Malaysia so far.
No.
At the moment, you will treat as supportive and symptomatic treatment. But yeah, okay, that's all.
Okay. So that's important also to note. Hot water immersion was utilized. Important to know what is the temperature was used, for how long it was done. So there is a protocol for hot water immersion, and should not be done in concurrent. If you're given analgesia to patient, then it should not be performed. It could mask the pain, and that could give a false impression of something is working. So especially if you've done a block on the patient, that definitely hot water immersion is contraindication. Okay, all right. So I think that's good learning points here. So thank you. Shall we move on to the next case?
Before we're moving on, Prof,
Oh.
we have a
Oh,
question.
there's a question. Okay, question.
As what
Right.
was mentioned just now, hot water immersion is important in this case. We'd like to ask, is there any evidence of hot water immersion can actually denature the stonefish venom proteins and reduce the systemic toxicity, or it is purely just for analgesia, or maybe other function in this?
Maybe Dr. Zainal can answer that.
I think at the moment we don't have any good evidence to say that the hot water immersion will neutralize the venoms. But for mainly for the pain management, to say that it is really reduce the pain is actually more of the what we call it. Yeah, it's
Modulate.
only it's a modulator for pain modulator. So that's why I think I agree with Prof as well. Once for the hot water immersion, you don't combine with a local block of any local anesthesia. Okay, that's all.
There's a question on the chat box. He thinks that the symptoms was aggravated because the patient had to swim for an hour. Was that mentioned? And after being stung, he continued swimming. And yeah.
No. He went to the army camp.
Yes, Doc. That's why
he didn't swim to the army camp.
I know.
but then it's true that
No,
movement,
I am
mechanical
reading
movement.
from the question. From the question.
Yeah. But patient was walking, of course, that could spread the venom. One thing, make things worse. Yeah. But anyway, what Dr. Zainal said is true. Just for simple argument's sake, when you're doing a hot water immersion, you are actually heating up surrounding of the limb. But you want to reach the venom if it was supposed to target the venom. But this is if it is a puncture wound, it could be deep, very deep into the tissue. So how much of the heat in that due time will heat up that venom in that depth from the surface. So it doesn't really make sense that 44, 45 degrees will reach to that level of depth in the tissue to denature venom, So it's more like, it's on the surface and therefore maybe masking the pain. Pain is now transferred from the point of puncture to the skin. So that's the part, the issue about pain modulation. Slightly different if the sting is from a jellyfish, which is very close to the surface of the skin, right? So that temperature, so-called hot water, might reach that micro millimeter of depth of the venom deposition. But if it's a deep puncture from a spinous fish, it could be, it might not, the heat might not reach that depth. Okay, so the question of neutralization by denaturalization of the venom is questionable to me. There's no so far evidence to suggest that anyway, so far. Okay.
Right.
All
Thank you
right.
so much, Prof.
Okay.
Let's move to the next case.
Okay, so moving on. This is our case number 2. So a 49-year-old male with no known medical illness working in a rubber estate presented to a hospital in Kedah 45 minutes after an alleged snake bite over left thumb while cutting grass. So on further history, there was pain and swelling over the bitten mark, and there was limited flexion of left thumb. So to all panelists, just a general question. Since the patient had mentioned that this was a snake bite, so when the patient is unable to identify the snake, what clinical features would Prof and doctors think is important to clarify to differentiate the different types of snakes?
Yeah, first thing I think you would be helpful if you can clarify where Kedah is, because not all of us here are from Kedah.
Unfortunately,
you,
it was just written as Kedah, so we do not have the exact location of where the snake.
yeah, but where is Kedah located in Malaysia?
North.
North where? North Pole? North of Peninsula Malaysia, just near the Thai border. Okay. So since we already get that geolocation, that could help as well to know where Kedah is, because our panelists are not from Malaysia, except for Dr. Zainal. Yeah. Okay. So that helps a bit. So your question is, what are the sign symptoms that we look for?
Yes.
Okay.
What to ask?
So what to ask? Okay, M.
Yeah, since it's a rubber estate, meaning there's lots of trees,
Okay.
and then depends on the foliage that where that the snake or the incident occurred, and yeah, left thumb. So left thumb, like if he's standing,
How do you get into the thumb? So
how the
it's on the
thumb, like
ground. So most likely it's on the ground, right?
maybe scrolling.
No, because it was a cutting grass, so it's lower down to the ground. Okay, that's interesting observation. All right, and that's pain and swelling. Okay, quite fast, I think. If the symptoms here appear to be 45 minutes, okay, to reach the hospital, less than 1 hour. Satria, what we can do with this very limited information at the moment?
Yeah, I think that he was bitten by the snake in the upper alley. I'm not sure that is like in the upper in the like the
Plantation.
forest
The plantation, rubber plantation,
or the plantation.
rubber estate. Yeah.
And did he see the snake?
Did he see the snake?
No description.
No description. He didn't see the snake. Okay.
No.
Could be anything. All right. Dana, you want to try to figure out? At the moment, very limited information, but we've gained some information there.
Yeah. What did he do to the wound site after the been bitten?
Before
Later?
coming to hospital, right? Yeah.
Before coming to yeah.
Okay. All right. So maybe our moderators can add on a bit more.
So moving on to the further information that we had gathered. So during his presentation at ED, his BP was 139/85, which was slightly on the higher side, with pulse rate of 74, which was normal, SpO2 99% normal, but his pain score was on the higher end, which was 8/10. On examination, he was alert, pink, GCS was full, able to speak in full sentences, warm peripheries, capillary refill time was less than 2 seconds, no ptosis, and not in distress. However, on left thumb examination, there was fang mark over the dorsum with no dermonecrosis, and there was swelling up to the proximal forearm, tenderness, range of motion was limited, pulse was palpable, compartment was soft, and the rate of proximal progression was 27 centimeters.
That's from the first time arrival, right?
Yes,
Swelling is 27. But one thing I want to point out here, we don't really use the term fang mark because we don't know whether it's a fang or not. So what we have there on the observation by clinical description is a puncture wounds. right? So those are 2 puncture wounds and it's bleeding, still oozing blood, swelling with underlying ecchymosis. Okay, so anyway, yeah, Sataria, this is your area. You're very close to the border to this place, Thailand. Yeah.
Okay. I will check for right 20-minute whole blood clotting test and
Okay.
coagulations and CBC.
Mhm.
However, um, right, these lesions, I think can be by both hematotoxics or even neurotoxic. You have to concern about like his airway, his neurological symptoms that I will ask for. Even
Yeah.
right, I am not sure that is there like active bleeding from the
Mhm.
the lesion. This is right. So it
Yeah,
can
it's
be like
still oozing. Yeah.
hematotoxic. The most
Mm.
the most I think that maybe yeah
The most probable, right?
yeah
So you're thinking of a pit viper?
pit viper. Like I
Yeah.
think that in the south
Well, we
maybe it's
don't do that.
yeah
We
pit
should,
viper.
most
Yeah,
likely pit viper. So that's why we're doing the test that you asked. You want to comment about the lesion or swelling
Yeah.
or what's
Also
the findings so far?
I agree with Prof. Sataraya, and then um the lab test that's necessary, and also like thinking of it's more of like on the hematologic side, as you said, and then pit
So
viper
yeah,
comes to
so
mind.
blood test has been sent. Okay, you thinking of maybe the usual the platelet count, the coagulopathy, coagulation profile. Those are the most important. You mentioned the 20-minute whole blood clotting test, but in Malaysia we don't do that. In the hospital we have quite good lab service, so we straight away send for the lab. Yeah. Okay, Zaina, what do you think?
Yeah, first of all, how in the history that he said he was bitten by a snake, but then he didn't see the
See the
see
snake.
the snake.
That's interesting, right? Yeah.
That's
Okay.
why it's in the
Number
thumb,
number
and then yeah, he was cutting grass, but like the
yeah.
motion, the
Could be,
motion.
he could struck two different nails on the board in the bush that can cause this, right? Possible.
Okay,
So
but
it's
I
going to
think
be
it's yeah.
yeah.
It sounds based on the history on the location, geolocation, based on the clinical findings on the examination of the hands, uh, more towards pit vipers, pit viper bite. Possibility for this one, I'm more towards of laying pit viper.
Okay.
Because of the geolocation and plus the evidence of ecchymosis and the
Okay.
bleeding side.
All right.
Okay.
Okay.
All right. So moving on. So
Wow.
Yikes.
so on initial management, what was done was 3 vials of monovalent antivenom was given. And at that time, his albumin was 41, ALT 19, ALP 74 with AST 22, and total bilirubin was 11, which was all normal. LDH was slightly raised, 205, with hemoglobin 15.5, which was normal. Total white cell count was also normal, but his platelets were extremely low, which was only at 9. His renal profile was all normal, with creatinine kinase 278, which was raised, and his PT, APTT, and INR was raised. So post antivenom, he still felt tense over the left upper thumb and pain on the finger movement, with pain score now of 4/10, and his RPP was 6 centimeters per hour. Blister near the bite mark was also noted, with compartment increasing in swelling, no active bleeding, and no lymph node swelling.
So which antivenom was given?
Monovalent.
Yeah, which monovalent antivenom?
For pit viper, it was
Which
for
which pit viper?
Which
Malayan pit viper.
Malayan pit viper, Calloselasma rhodostoma. Okay, and the reason for this choosing for this antivenom, is it before or after consultation to Rex?
Before.
Or so they have already started earlier. Okay, that's good. So what's the indication for antivenom for this patient, Sataria? Maybe.
I think like coagulopathy
Mm.
is quite interesting that I would like to point out that if you have right polyvalent antivenom, will you give like polyvalent? Because I agree that the most possible
Mm.
snake is Malayan pit viper in this case, because from the locations that he was bitten, and the regions of the regions that it like very swelling with active bleeding and coagulopathy and thrombocytopenia. However, mm, in our experience, sometimes only like the lesions cannot differentiate much for like green pit viper and Marian pit viper. In some of our cases, green pit viper can cause very severe local lesions and with blisters and other. And in some cases, some patients did not have any local effect from both. So I think if the patients was very severe, like unmeasurable coagulation fact, or like this case that cannot measure the coagulations and the platelet very low, like 9,000. Maybe if in case of doubt, I will give polyvalent antivenoms to this patient.
Okay.
But I wonder that because he was bitten at the thumb, but he did not see the snake. Uh, I I will ask more. But however, if the snake is not green, it still can be rice maracillus also.
Yeah.
So in the severe cases, I will choose polyvalent
Yeah.
hematotoxic and antivenoms.
So this is a situation in southern Thai possible, right? That's your choice. Okay. M. Do you see such thing in Philippines or
No.
American Samoa?
There are no snakes here, I told you already.
Okay, you're probably all in the government
I'm
house.
very lucky. I don't need to worry about snake bites here.
Okay.
And no
All right.
rabies as well,
Yeah.
strangely.
Okay. So maybe Dr. Zainal can give a Malaysian perspective about this so far. Why do you
Yeah,
use
yeah,
monovalent rather than polyvalent?
yeah. I agree. I agree for the monovalent antivenom for Calloselasma rhodostoma antivenom. Mainly because one is geolocation at the northern part of peninsula, and then it's also at um the lower at the ground level it was bitten. But even though the other green pea viper possibly still we can find at the lower at the ground level, uh but because of the signs on the swelling with the ecchymosis and the bleeding, so it is more of a most likely it is because of the Malayan pit viper.
Okay.
So I think I agree
And
to give the
we don't have Russell Viper. That's one
yeah, we
thing
don't
that
have
our
yeah, we
neighbor
don't
in
have
Thailand should be
yeah.
worried about, right? Yeah.
Mm,
But then that would kind of reflect on the renal profile where you might
yeah.
develop a kidney failure
Mm,
due to direct effect of the venom from Russell's viper. But we don't have it here in Malaysia. Yeah, so those are kind of an interesting deduction. So what we use what we call syndromic approach one, but we also use what we call intelligent deduction. That's the sort of like advantage that if somebody consulted to Rex, if they don't consult to Rex, most likely they will more choosing towards polyvalent. But after consultation to Rex, most likely from the assessment that we ask, from the information that we ask, we can deduct that most probably, it's not likely, but probably most likely is, most probable is Malayan pit viper in that area and region for this patient. You can see the platelet is dropping very fast. I'm not sure what INR more than 3 means, but INR doesn't use minutes, but I assume it's all prolonged. Okay, yeah. Okay, so anything else, moderators, about this? So at the moment, our working diagnosis, what's the working diagnosis, Zena? Do you think? It's unidentified snake bite, right?
Yeah, this
So
yeah,
I
unidentified snake bite, probably because due to Malayan pit viper.
okay.
Mm.
Unidentified snake bite probably due to Malayan pit viper bite and venoming.
Mm.
Okay, systemic already, right?
Mm.
Can I ask a little bit about like total bilirubin is 11? What is the unit of
Yeah, maybe moderators.
Hmm.
Could you repeat the question, Prof?
the
Why the total bilirubin elevated?
Total
Uh-huh.
bilirubin is raised or normal or low?
It's normal.
So we
Yeah.
don't. Okay.
Just a comment then. So for like students, when we put our results, maybe we can put on the range, because not all
Everywhere the same.
laboratories is
Yeah.
similar range or reference range. Yeah.
References. Yes. Yes. The units as well. Yeah. Agree. Okay. Right. Okay. So next, what do you want to show us?
So moving on, the further management that was done, medications given was IV tramal, 50 milligrams, TAP paracetamol, IV augmentin, TAP amlodipine, 10 milligrams, and IV unacin, 1.5 grams, along with, as mentioned, antivenom. The first dose was given at ED. Second dose was in the ward due to persisting swelling and blister on left proximal forearm, and the third dose was also given in the ward in view of coagulopathy. So progressively, his RPP trend was reducing to 0 centimeters at day 9, with pain score of reducing in trend, and his serial blood investigations were all improving. So this was his progress.
So just before you go, the first dose, second dose, and third dose, is there a what do you call interval between them? And what does first dose means? Just now you said you gave 3 vials, so that's 1 dose, right? So the second dose is also the same 3 vials, and third dose is the same 3 vials. So total is 9 vials.
Yes, Prof.
And the indications to give the subsequent doses, was it documented?
The ones that were mentioned there, Prof. Persistent swelling, and then his coagulopathy was worsening.
Yeah. Okay. Is it worsening or still remain in coagulopathy? So that's another thing, right? So it might just now no reading, suddenly got reading, but still abnormal. Doesn't mean that that's indication for antivenom. Because it's already an improving trend. Why do you want to give antivenom? If it is worsening or you can't still read the coagulopathy, then you might want to consider a patient with active bleeding. So there are indications post antivenom for a repeat dose. So you need to go to look at those indications to repeat antivenom. So swelling is a persistent swelling. What does persistent swelling means? You don't wait until it's get. So persistent means either is it deceleration, or is it cruising, or what, or static. I assume persistent means static. So that's not an indication to give antivenom, right? So blister is definitely not a feature to give antivenom. It's a subsequent extravasation of fluid into the third space, so it's not antivenom effect. So it is due to the venom from the metalloproteinases, but it doesn't mean that antivenom should be given as a top up just because of a blister. Okay. Yeah. So that needs to be justified lah, when you want to give or not to give antivenom as a top-up dose.
All right.
So, okay. So that's something that we learn maybe. So improving doesn't mean just improve, but improve and remain normalized. I mean, it's not fluctuating. Okay. So we do have issues with fluctuation, right, Zainal? Sometimes we give antivenom and then improve and then it becomes abnormal again. So there's a recurrence of envenoming features, systemic, for some of the pit viper that we have, especially the green pit viper. In the past it's called Paris hagenai, but now it's Trimeresurus hagenai. Before, yeah. Anyway, so this is what Callosolasma rhodostoma looks like.
Yes, Prof. From what we had built up.
Right. So diagnosis still remain unidentified snake bite, probably from a Callosolasma rhodostoma. Okay, but it's not a direct saying that this is could be the cause. Okay, but treatment. One more thing. How do you know that your treatment, the one that you give antivenom, is correct or not? Anybody?
Improving.
Improving. Yeah, that's right. So means that you give one dose antivenom, you see good improvement in the especially the systemic coagulation profile. Okay, if it's a cobra, then it could be from reversal of the muscle paralysis. Okay, so you need to note when exactly you give the antivenom and the interval of time it takes to observe this reversal of symptoms or reversal of signs. Okay, it's not just we give and we leave the patient alone like that. Actually, close serial monitoring should be continued even after you gave already antivenom. Very important to note these changes. If you don't observe closely, you will miss it. You will miss it. Okay. All right. So this to suggest it's not a failure of therapy. Okay. Uh, and therefore you give the appropriate antivenom basically. Even though this is not a polyvalent antivenom, so it shows that the monovalent works. So most likely it's from Malayan pit viper, right? Okay. Okay. So this thinking retrospectively, but this is where we were thinking prospectively earlier. So the finding now justify what we did before. So intelligent deduction. Okay. Right.
All
Right.
right. Thank you, Prof. So moving on to our next.
Also the health-seeking behavior, sorry.
Oh yeah.
For like, the gloves and, boots and all those things that, as part of our teaching later on when you go
Okay.
out into the
Yeah. Outreach program for the public to be more on the safe side. Okay.
All right. Let's move on to our third case. Okay, so a 39-year-old male with underlying alcoholic liver disease working as a rubber tapper presented with pain and swelling post-trauma after an alleged sting by a scorpion on his left index finger. So upon further history, he noted that the scorpion over the rubber tree after being stung and post-trauma denies any self-irrigation and only kept the finger dry. And he presented to emergency department only 4 hours later in view of no transportation. So there's a sustained bruises over the stung area along with pain and swelling progressively with full range of motion within 4 hours of being stung. So to the panelists, maybe to Dr. Amelia, based on your expertise, which scorpion species are most likely responsible, especially maybe in
another one, scorpion.
Do you
I
have
would
scorpion? Do you have scorpion
I,
in
some I none
American
no none
Samoa?
nothing reported, Doctor, but like as
Okay.
I would think like with the species I think it doesn't really vary as to how do we approach the sting of the scorpions. Of course, the basic
Principle.
analgesia, tetanus vaccination, and oh, did he see the scorpion now? This at this time, this per patient, he
Yeah,
saw
he saw the
the
scorpion.
actual.
He saw it.
Oh, yeah. And with regards to species, it would be Dr. Kao who would tell us about this.
No, we asked Prof. Sataria.
I
So
still don't know about the species of the scorpion because in our experience in Thailand, we don't have the system the patient who develop like systemic effect from the scorpion. Only just the local effect and pain. So we give only like supportive care. But
okay.
I'm not sure that in other country they mentions about like neurologic effect from scorpion bite. So we have to concern that again
Scorpion sting.
about the sting. Okay.
Yeah.
How about in Malaysia? Maybe Dr. Zainal can tell us more. Like which scorpion species are most likely responsible for all these things?
Interesting.
Yeah.
I'm not expert. I'm not expert on identifying the scorpion, and then based on the history as well, I'm not sure which I can identify it just based on the history. But I would like since patient has alcoholic liver disease, and then we look whether the bruises was there anything done to the sting site that cause bruises, either any manipulation of the wound before arrive to hospital, or how bad the liver disease for this patient. Was the bruises is directly because of was it because of the scorpion bite itself, or because of the other cause?
Okay.
So to say that which species, I cannot answer that at the moment.
Yeah. All right. Thank you, Dr. Zainal. Okay, maybe.
Anything else? Anything else you can provide us with regarding this case?
Yeah, sure.
Pictures.
We move into the
Okay.
examination. So, on presentation at the emergency department, so the BP level is high, given the reading of 199 over 104 millimeter mercury. However, the pulse rate, SpO2, and also the temperature was normal. On examination, the patient is alert with warm peripheries, CRT less than 2 seconds, no tachypneic, and the pupils is reactive with sclera jaundice noted. Yeah, most likely due to the liver problem. Yeah. And then over the left upper limb, there's a minimal swelling over the tip of the index finger with bruises and full range of motion. Otherwise, the lungs is clear, cardiovascular system, dual rhythm, no murmur. Abdomen examination was soft and non-tender. Yeah. So at this stage, since the patient presented with a BP of 199 over 104 millimeter mercury, we have a question here. Can a scorpion venom trigger the transient autonomic instability, or is this likely incidental in this patient with underlying liver disease?
Dr. Zainal, what do you think?
Number one, what was the previous medical history? Does he has hypertension, and does he's on antihypertensive, and whether it is complied to medication or not? Number two, pain itself can stimulate and cause the blood pressure a bit higher. And then whether the scorpion itself, I'm not sure. I don't think in Malaysia it can cause a directly effect because of the scorpion venom bite. But probably we need to look at what are the underlying disease that this patient has.
Okay. It has a ecchymosis there on the sting area. Is that due to manipulation or is that due to the sting itself?
It is due to the sting itself.
Wow. Okay. So there could be
That
some.
Yeah.
cytotoxic effect, or don't know, maybe.
He didn't suck the wound like the usual thing, or suck or mop the wound area. Any
No.
manipulation?
No, we got no info on this. Yeah.
Okay. All right.
Mm.
Okay. Sataria, you want to add on? What do you think? Your blood pressure and envenoming from scorpion. Do you see
Yeah.
any something like this in Thailand?
Yeah. And one thing that I am not sure that he has a lot like pain a lot, because like from pain it can cause like high blood pressure.
Depression.
Also, I will give them analgesia to reduce his pain and look at his blood pressure again.
Yeah, but be careful of the analgesia. He has an underlying liver issue, so you have to consider also what you give for the patient. Things might worsen the liver disease or might not. Yeah, prolong the effect. Okay. Anyway, yeah, I agree. It's difficult to just say it's due to the venom for causing the raised BP. Uh, if possible, we check back patient. Of course, patient already has a past history, so you can check the past entry of vital signs of patient, so you can compare whether patient has or not hypertension. So if it does have, then might not be due to the envenoming. Okay, and I don't think the swelling is progressing proximally as well. So it's only local at the sting site there. Is it? Or is there any other information you want to give us?
Let's move to the next slide.
Okay.
Okay, so the investigation done, full blood count was all normal. Coagulation profile, there's prolonged PT and APTT noted, and also the INR level is raised as well. Creatinine level is normal. Creatinine kinase test was slightly normal. X-ray examination, there's no any foreign body and fracture seen. So for their initial management, this patient was given intravenous tramadol and maxolone, and also intramuscular ATT. And he was also given with IV hydrocortisone and pyritone, and 2 pints of normal saline for hydration. And he was then continued with IV tramadol, maxolone, and hydrocortisone. So there's a question here, like what's the indication of giving hydrocortisone and pyritone in
Exactly. I was
patient?
about to ask.
So maybe is there indication? So this is more reactive rather than actual thinking process. Maybe. So
Swelling, for the swelling.
yeah, but there's no rash. Nothing doesn't suggest that
Yeah.
it's due to an allergic reaction, not
And may I ask
hypersensitivity
what is
reaction.
pyritone? May I ask
Piriton
what?
is like chlorpheniramine maleate.
Hmm.
Chlorpheniramine antihistamine.
Oh, okay.
Yeah. Sorry for that. Yeah. So I don't see the reasons for this medication. What do you think, Sataria? Is there a role for giving IV steroids and antihistamine for this case? I don't see the.
I I don't think that steroid is necessary in this case.
Mm,
Yeah.
Histamine that just only like analgesia is
mm,
maybe enough, because
mm,
if you give steroid, it might increase the risk of infections. If you don't think that the patient has the anaphylactic or allergic reactions in this case, I don't
mm.
think antihistamine and steroid should be like prescribed or
Right.
treated.
I don't know whether a single dose of steroid will have a risk of increasing the risk of infection. Typically, it's a repeated dose of steroid might suppress your immune system, but a single dose, I'm not sure. I don't think it will be causing the significant drop in your immunity. But I agree it's not really indicated in this situation. Zainab, what do you think?
Yeah. I don't see any indication.
What about the abnormality in the coagulation profile there? Is that due to the
Okay.
envenoming or?
Yeah. Do you have
Yeah.
the liver function test
No,
Yeah.
result?
you don't.
No.
Yeah.
Remember,
But
he's got alcoholic liver
yeah,
disease.
Yeah,
yeah.
patient INR
In
is raised,
Chinese.
so that's
Mm,
most likely from the liver itself, not
mm,
direct from the envenoming.
mm.
Okay, all right. Anything else you want to show?
All right. Move on. So the patient's progression is clinically stable and well, and there's a resolved angioedema. Afebrile, lungs was clear. BP is normal, pulse rate and SpO2 and also temperature was all normal. And then the further plan is to continue the hydrocortisone for 1 day and then change to oral prednisolone. And they also cover this patient with Piriton and to monitor for any rebound allergy and take serial blood tests. Yeah. So to the panelists, do you agree with this management plan or would you do it differently?
I'm wondering, no antibiotics this time. As well as, did you guys give anti-tetanus? I didn't see.
Yes,
Right.
it's given. Yeah,
It was given. Okay.
it was given.
Yeah. Yeah, Zainal, what do you think?
Well, suddenly it come angioedema and allergic. Was the patient diagnosed with allergic? Because it was mentioned about rebound allergic. It looks like they diagnosed as allergic and they're afraid of it become allergic again. Was it
Yeah.
was the diagnosis of allergic was mentioned in the first diagnosis?
Angioedema was not mentioned before, right? So suddenly
Uh,
it says angioedema. So that suggests a hypersensitivity reaction.
so
It was not.
yeah, based on the history and previous examination findings, I don't think patient has allergic reaction. And for me, I will not give hydrochloride and Piriton on the first place, and as well as for the continuation of the steroid and the antihistamine for this patient.
Okay. So the next question is, do we do what happened after patient discharge? Do we do further testing for possible hypersensitivity? Do we have tests for that and for subsequent worsening of reaction if patient got stung again by a scorpion? Do you do that tests in Thailand or in Philippines or
So,
Samoa?
no, doc.
No, you don't. Okay, yeah.
But as I've mentioned, I think it's good to give some antibiotics for this guy.
What's the indication for antibiotics?
I'm thinking that, like, the work area,
The what?
location, work area. No.
Oh. No, it's doesn't matter where you work. The issue is whether your own body able to handle or not any offending uh, bacteria that come in, right? So your own immunity. So if your immunity is, I don't know whether somebody with a chronic liver disease will have a
I mean,
issue with immunity or not. The bone marrow are working well. Does the liver have any issue with defending itself from a bacterial infection?
because remember, doc, these scorpions are like, just on the ground and all these things.
Yeah,
We're
yeah,
not sure, like, the fangs may have harbor those organisms too. So I am thinking along that line.
yeah. It's actually you are right. There were studies before that suggest that there are possibility or chances of you getting secondary infection from scorpion sting, spider bite, centipede bite.
Yeah,
Uh,
centipede.
yeah,
Yeah.
so this bite and so on breaches the skin, and skin might be introduced to the organism that this organism has carried in the fangs. So that predisposes patient to secondary infection. But the chances is the rate I think in Malaysia is so far we find that very low. Very little patient develop cellulitis secondary to secondary infection, bacterial infection after bite or sting. Yeah. So we don't prophylactically use antibiotics to treat the patient or to manage the patient because we're not treating anything. It's more prophylactic, right? So we are treating ourselves, our self-conscience. Defensive medicine. Okay. All right. I hope you don't practice that in American Samoa. Okay, so any other questions that we can perhaps entertain or any other things?
Yeah, so
Oh,
I believe that
Doc, the protective health-seeking behavior,
yeah,
gloves, all these things,
yeah, okay. So what
boots.
is this a scorpion that's sting the patient?
yes,
Oh,
this patient was stung by the Asian forest scorpion,
Wow,
spinifer.
how
Yeah.
how how, how was
amazing.
this not shown earlier?
Huh?
This scorpion was brought to the hospital
Oh,
or
Description, Dokal.
uh, AI generated, is it? Don't know.
no. It was in the doc. They took picture of the scorpion. Yeah.
Okay.
Mm.
So this is the Heterometrus spinifer, Asian forest scorpion. It's one of the largest scorpions that we have, but in
Aerobitus
terms of
spinifer.
venom, it's not so harmful to human. It's just a local. But you can see just now, it can still cause. I don't know whether how it will heal, whether it will heal with ulcer there on the tip of the thumb or not. So we don't know. So that's another issue that we have to follow up with the patient after discharge. Okay. Right. Do we have time for another case or not?
Yeah, I don't think so because
It's very long, right? The next case is
yeah.
long?
Next
Okay.
case is long. Yeah. So
Okay.
and the third case, yeah. So I'll pass the floor to
Oh, any questions first? Any questions from the floor? Any question from the participants? Any of the cases? Any other questions that we have not answered?
I think that's all. So far, we didn't receive any other question from the chat box. Yeah.
Okay. Thank you. Interesting question. Interesting cases. Discuss cases. Very uncertain type, but just to elicit the important points in clinical toxinology. Do not easily how should I say uh, agree on things which you are not certain. So okay,
Thank you.
right.
So
Thank
I'll
you.
proceed now. Thank you to all the panelists, Dr. Emilia, Dr. Zana Abidin, and Prof. Sataria, as well as our advisor, Prof. Khaldun, for sharing your expert opinions in the clinical management of toxic-related diseases during our case discussions just now. So due to time constraints, we are unable to discuss the other cases prepared, so we would now proceed with the Kahoot quiz. So now, students, please join the Kahoot quiz that has been prepared by Prof. Khaldun to test our knowledge in clinical toxinology. Let's see who will be the champion to receive a special prize from Prof. So now, Prof. Khaldun, the floor is yours.
Excuse me, is there any playtime? I would like to like comment a little bit about the case. Is there time for me like 1-2 minutes?
Yes, sure, Prof.
Yeah, okay, because I saw the second case and I would like to share our experience that last 2 weeks we had two patients who were bitten by the snake. Final diagnosis was Malayan pit viper for both cases, but they presented with fainting and collapse, and then the with the severe local reactions, and then the doctor gave them right copper antivenoms, but but from the lab there were coagulopathy with low platelet count, and after that we changed to polyvalent and Marian pit viper, and they respond to Marian pit viper. That why we diagnose Marian pit viper envenomation. So I would like to point out that some cases with severe envenoming, they might present with fainting or collapse.
Yes.
Especially that we saw in like Marian pit viper and Russell viper is quite common. So sometimes it's very difficult. The doctor will give antivenom for neurotoxic snake first. Yeah, thank you.
Yeah, that's very interesting. But why do they fainted? Is it because of anxiety? Is it because of the pain? Is it because of the direct effect of the venom? Or what do you think?
We ask about like anaphylactic reactions, other sign like blood pressure, but no other sign with anaphylaxis or anaphylactic reactions. But I saw in WHO guideline that they mentions that fainting or collapse might be the common first sign for systemic envenoming. So and we don't know why, but we saw some, like especially Lassell Viper. We checked the CT scan of the brain, but we did not see the infarctions or hemorrhage. And then after treatment, they will gain their consciousness. And these two cases, a child and one was an adult, they presented the same, like fainting, collapse, and then gain consciousness, and then coagulopathy with severe thrombocytopenia, unmeasurable for INR. Thank you.
So it's the other way around here. Maybe Dr. Zainal would like to share our recent paper, our publication on the Naja species in Malaysia, consulted to Rex. We had also documented a death, but the situation where the child collapsed, but they think it's Callosalasma rhodostoma. So they gave pit viper antivenom. Obviously, will not reverse the neurotoxicity. They just based on the local feature and also swelling, and they think it's in Kedah, also the case in Kedah, and they straight away think it is Callosalasma, but and gave the Callosalasma antivenom, and the child eventually died. Okay, so we only been consulted after the case, after the death, and we found all the evidence to suggest it's not Callosalasma, it's more towards Naja species. So that is, as you said, it could be, very difficult sometimes to make a decision just looking at the presentation. So we have to really choose the most appropriate at that time. What are the antivenom that is most relevant for that particular patient? Yeah. So I agree. It can be confusing. It can be difficult. I think that's what I think Dr. Zainal pointed before. Rex is there to help with the diagnosis, make the appropriate choices of treatment. Okay, shall we do the Kahoot now? Is that okay? Thank you, Satria.
Thank you.
For the comment. Very interesting. Thank you.
Yeah, good.
Okay. Next is the champion. Let's see. 687 A18
Wow.
A582 TZX.
This game is really cute, and until now, I
And
don't
the
know how to
champion
play
who
it.
wins the rest is Junet.
Congratulations and well done to the champion. Please send your contact details to our host, Dina, directly via the chat box to claim your prize. Now, let us welcome our panelists. Dr. Zainal Abidin Mohamad to deliver the closing speech.
Yeah, Assalamualaikum warahmatullahi wabarakatuh. Very good afternoon. Thank you very much, the organizing committee, for inviting us as a panels for discussion today. And also I congratulate Prof. Khaldun and as well as the medical students from UKM for organizing this very important and very fantastic webinar. I think not all the universities. I think this is the only university that they uh, do a very specific webinar on toxinology for the medical students. I think this is a new effort to introduce the medical students on the toxinology, and I hope it will be extended afterwards. And thank you very much for all the panelists for participating in this webinar. And I hope all of you will have uh, lots of benefits and will understand a lot on the toxinology. And I hope after we have a few episodes of webinar series, then I hope your findings on the understanding and the confidence on the information or on the toxinology will increase later on. Thank you very much, and thank you. Assalamualaikum warahmatullahi.
Okay. Thank you so much, Doctor, for the inspiring closing speech.
Now,
There are questions, not questions, but like
Yes, M.
there are some questions. Oh no. One question I noted is like, he's a he's a disaster medicine specialist practicing in Saudi Arabia,
Okay.
PhD student, and then he's say asking with the rising temperatures and climate change, do we expect any changes in the just geographical spread of toxic organisms, and what your advice in treating toxic events in low resources setting?
Yeah, I mean, it is the kind of association, especially also with the rising temperature in the sea temperature. You
Yeah,
might see higher
jellyfish.
jellyfish blooms in these waters. So obviously, you might have a higher incidence of encounter between animal and human, and you might get more cases. So um, in the resource setting, I would say increase more of your awareness program, so
Awareness
that people will
programs.
reduce the number of cases rather than treating. Prevention is better than cure. So
Cure.
that's I think the best way to do. So put more effort and more resources, funding, and so on to increase the local knowledge, the people who are exposed to these areas, and also everybody in general. And please also ask them to learn how to do CPR, basic life support.
Yeah.
Uh,
Yes.
that's a continuous effort that we've been doing for every course that we do. Is to encourage people, the public, to learn how to do CPR. That's the case that we saw just now, the jellyfish. It was the CPR was done by the public for 45 minutes, and by the time ambulance arrived, it did not reach ROIC, but the effort was initiated by the public. So that was a good thing, that we have some knowledge in the public of how to do the appropriate basic life support. Okay, yeah. So any other question that we can answer or respond to?
I don't think there's any more.
Yeah.
Yeah, I think that's the only question.
Yeah.
Okay. Okay. Thank you so much, Hisham Al Dinar from I don't know, Saudi Arabia, all the way. Wow. Thank you. All right.
Yeah, especially these days now. Oh my God, in the Philippines, the typhoon is just like coming one after the other, and then of course leptospirosis,
Oh,
black
okay.
lights, etc., etc.
Yeah. Could be. Yeah.
So yeah,
Okay. Thank you so much, everybody. Enjoyed it. So, moderators, anything last words?
what
I
the?
would like to present the e-certificates to our panelists as a token of
Okay.
appreciation.
All
So
right.
this is a token of appreciation for Dr. Emilia B. Santa Maria. So let's take a picture to commemorate this moment.
Commemorate.
Okay, so in 3, 2, 1. Thank you so much for spending your time with us today. Next,
Yeah,
this is
much
for
fun.
Dr. Zainal Abidin Muhammad. So let's take a picture together in 3, 2, 1. Thank you for your sharing with us today, Dr. Zainal Abidin. So next we have Prof. Sataria Trakul Sritrai. So please have a picture with us in 3, 2, and 1. Thank you so much, Prof. And next, we have our advisor and our panelist, Prof. Madya Dr. Ahmad Khaldun Ismail. Let's have a picture together in 3, 2, 1. Thank you so much for your sharing with us today, Prof. Khal.
Yeah. Should I grab the opportunity, Dr. Carl, to invite?
Yeah, sorry. Dr. Emilia want to share something for the Philippines?
Yeah, we'd like to invite you guys for the first Toxinology Congress and the AMSEM as well, December 3 to 7. Oh, 3 to 6, sorry. And 7, you can come join the other activities.
Yes.
This is gonna be in Palawan, Puerto Princesa. Yes, of course, in the Philippines. So, those who are interested, we will be posting some information on our chat groups, and then if you can share it to your colleagues, then that would be really good. Thank
Okay.
you very much. Terima
See you.
kasih.
Sama-sama. See you in Palawan.
Yeah.
December. Yeah. Okay. So
Professor Soteria, see you.
Okay,
yeah, Sataria.
Dr. Zainal.
Okay, thank you. See you again.
Before we end our
Okay.
webinar, can we invite all the panelists and advisor to turn on your camera for a quick group photography session?
Okay.
Okay, maybe siapa lagi? Dr. Zainal and Prof. Oh, okay. Right. Okay, on my count. Ready? 3, 2, 1. Okay. All right.
So we have now come to the end of our webinar. To all participants, please scan this QR code to fill in the feedback form. The screen will be shared shortly. And this is to receive your e-certificates, and also MMA CPD 1 point will be awarded to the Malaysian doctors attending. Please ensure you complete the form with your full details to receive your CPD point. You may also click on the link in the chat box to fill in the form. Once again, we thank all of you for joining us today, and we hope you have learned something about clinical toxinology. See you in the next episode of Clinical Toxinology. Is it relevant for medical students? Bye-bye.
Terima kasih.
Bye.
Thank you all. See you next year for the next season,
Yes.
season 5. Yes.